This meeting is being recorded.
Hey everyone, good afternoon. I hope everyone had a great Easter. My name is Bill Ikest. I am a past president of Georgia HFMA, and I'm happy to welcome you to the 2023 Virtual Spring Payer Forum. As you may have seen when you registered, we have payers presenting all week. These sessions are being recorded, and we'll be able to provide those to you so that you can listen to them again or share them with whoever in your organization may have wanted to attend but was unable to attend. So be looking for those in the weeks to come. Today we're starting out with Medicaid and Gainwell Technologies. Our good friend Janey Griffin Weaver is participating as our presenter today, and she's got a whole supporting cast with her today who are going to address any questions, issues that you might have. I would ask you, if you do have any questions for them as the presentation is going along, if you would please put those down in either the Q&A or the chat section. You'll see that tab at the bottom of your screen, and we will go from there. So this is scheduled to go from 1 until about 2 o'clock. I don't know that we'll go that long, but if we need to, we certainly can. And I just want to thank you for your participation and your support of Georgia HFMA. Again, tomorrow we'll have Medicare at 1 o'clock. Wednesday, we'll have United Healthcare at 1 o'clock. Thursday, we'll have Anthem Blue Cross, now known as Elevance, I think it is. Sorry. On Thursday, and then Friday we will have a representative from Ambetter as well as a representative from Humana presenting for us from 1 to 2 and 2 to 3 on Friday. So again, thanks for being here. Janey, I'm going to go on mute and turn it over to you.
Thank you. Good afternoon to everyone. Hope and pray that everybody had a wonderful Easter. For the agenda today, we will be discussing the contractual and transfer agreements. We'll talk a little bit about the effect that it has with the outlier contractual and transfer agreements as well. And then we'll go over some new policy updates, and we'll open it up for Q&A. So let's get it started. First segment that we'll discuss will be with the hospital transfers and contractual agreements. With hospital transfers, it is helpful for the provider to indicate if the patient has been transferred to their facility from another facility. Some of the things that we want the providers to be aware of that you need to make sure is available to us is where you have your admit date to show as the date of the transfer, and providers should clearly note the reason for the transfer. An example, as we have here, would be due to a higher level of care that's needed, or services not available at the admission hospital, or maybe patient or family convenience, as well as inpatient rehab or LTAC services. The provider should also note that if a contractual agreement is in place for the transfer back to the originating facility, this gives the reviewer, which is Alliant Health, a better understanding of the full clinical picture, and helpful if it's a duplicate for prior authorizations. It may come to a situation where those authorizations need to be combined. There's also somewhere where you can select the contact us message for Alliant Health and give them feedback for the claims that appear to be complex or requiring escalation to a clinical supervisor, manager, or director. The screen that you have, that you see in front of you now, wanted to talk a little bit about this screen that plays an important role in what we're talking about that deals with the provider transfer information. So always indicate if it is a transfer, you are stating if it's a transfer to your facility or from your facility. And then we would like for you to document as well, if it is due to that transfer, do you have a contractual agreement? Or if you do not have a contractual agreement. Again, that's information that will help Alliant Health to get your authorization correct. And it would also help you in providing your receiving your reimbursement. So with hospital transfers, if a patient is admitted in a hospital and must be transferred for admission to a second hospital for medically appropriate cause, and the claims for both hospitals fall into the same DRG, both hospitals will be eligible for payment. And keep in mind, we're talking about transfers. If the claims would otherwise be paid under the DRG rate methodology, each hospital's payment will be the lesser of the DRG rate or a rate calculated by the CCR methodology. If a patient is transferred from one hospital for admission to a second hospital for a medically appropriate cause, and the claims for both hospitals fall into different DRGs, or the patient is discharged from hospital B, each hospital payment will be for the amount that a non-transfer claim would be. However, we need for you to note all transfers are subject to either pre-certification or retrospective review. Okay, now we're going to talk a little bit about the hospital transfers that are due to non-contractual agreements. So for transfers back to the originating hospital receiving the back transfer for lower level of care is eligible to receive reimbursement for both confinements, okay? To ensure accurate claim processing, the originating facility must request an adjustment to the pre-certification date span and adjust any previously paid claim for the initial hospitalization and combine and resubmit as a single claim for both date spans. The dates of service spent in the alternate facility are reflected as leave of absence. So that's where you're going to put your LOA days, revenue code 180, with however many days it was that member was at the other facility. Once again, keep in mind, all transfers are subject to either pre-certification or retrospective review. Also, with the hospital transfers and it's hospital back, the department may approve transfers from a higher level of care facility to the originating lower level of care facility for continuation of a lower level of care, provided the higher level of care is no longer warranted, the level of care continues to meet the criteria for inpatient confinement, or transfer back does not compromise the patient's care. This is intended to provide a mechanism for Georgia Medicaid members to receive medically necessary level of care in the most appropriate setting and does not serve to replace or otherwise circumvent the terms and conditions outlined in the Part 2 Hospital Manual of Section 903.2, where it states services available through contractual shared agreement, in Section 1013 of transfer cases. This policy is not meant to allow transfers to lower level of care facilities to alleviate bed overcrowding for patients' convenience. Okay, all transfers are subject to pre-certification in accordance with Section 800 of the Part 2 Hospital Manual, and that's Section 800. You can also look at Appendix C, Section 8, for the reimbursement piece of the hospital back transfers. So here we have an example of one of the in-network transfer examples, and I'm going to ask Alliant Health to talk a little bit about this, please.
Good afternoon, everybody. My name is Lee Hamilton. I am the Deputy Director of the Prior Authorization Utilization Management Department here at Alliant. So our department is the department where you call and ask about the status of your cases, ask questions about policy. We are the ones that do all of the PA reviews for fee-for-service Medicaid members. So I just wanted to give you this in-network transfer because we understand that these get complex, they get tricky, and the ones that come across our desk are not the ones that are kind of those straightforward transfers. It's more the complex where they're dancing around the state of Georgia, or where their condition is requiring different levels of care. So in this in-network transfer, to just give you an example, I named them Apple Hospital. So you guys know that there's lots of facilities that are obtaining more and more different facilities through buying out different hospitals. So like your WellStar facility network is pretty big, and Emory, and those are just two examples. So let's just say in this example, you have a 6-year-old that had a rollover motor vehicle accident, pretty much a trauma event, and there was chest involvement. We know that this patient needed to be admitted to the trauma ICU at the initial Apple Hospital main campus. Broken leg, required surgery, multiple contusions to the face, had to have some imaging. It was unremarkable for the brain, but he did require test tube placement for a pneumothorax, needed to be on the vent, eventually was weaned, and he stabilized enough to go to inpatient rehab. So a lot of our kiddos, especially the preemies, a lot of our cerebral palsy patients have to require some inpatient rehab at some point. So fortunately, this facility has its own inpatient rehab, but it's 5 miles up the road. So they've got to transfer him to Apple Hospital Lakeside with just a leg brace. He had to get 3 hours of therapy a day for 5 days a week, PT, OT, working on transferring, walking, that sort of thing, being more independent. However, while he was there, 6 days after he was there, he developed a fever, and it was found that he had pneumonia. He continued to decline, so they had to transfer him back to the main campus where he originally was initiated. So at 2/16, he was sent over to Apple Hospital, and he's still in the facility, let's just say. So this is an example of one DRG. So it's across the entire hospital facility. Patient never went out of network. In this case, you would just need the first PA. You would make sure that you'd want to recertify it if that patient had to be within the hospital greater than the 90-day period. So for an out-of-net transfer, so let's just say at Apple Hospital main campus, it's a fabulous hospital, but it doesn't have all of the advanced care that this particular 76-year-old male needs. So he ended up in the cardiac unit with shortness of breath, found out that he had, I believe, some sort of congestive heart failure exacerbation. His EKG was abnormal, and he was non-compliant, but they decided that he, because of his continued deterioration, needed a pacemaker. So they were able to transfer him to Orange Hospital, 20 miles down the road. This particular hospital is known for its cardiac step-down unit, its cardiac ICU, its ability to do pacemaker insertions, open heart surgery. Patient was eventually sent over to Orange Hospital. He was on a nasal cannula. He had his surgery, pacemaker was inserted, and the postoperative care was provided in the cardiac ICU, and then eventually a step down. He was weaned off the oxygen, and eventually he was able to go home on 2/16. Since these are two different facilities that are outside of one single network, these would be treated as two different DRGs. It would require two PAs. Next slide.
Okay, thank you for that. So now we're going to talk a little bit about the contractual agreement. Okay. Contractual agreements come to play when covered services are not available or provided in the hospital where the member is an inpatient or outpatient. The services must be furnished by another enrolled hospital through a contractual agreement. The original hospital where the member is an inpatient or outpatient must bill the Medicaid program for the shared services or procedures along with the other charges incurred during that course of the treatment or inpatient confinement. The Medicaid program should only be billed by the original hospital for all of the charges that has incurred. Services furnished under the arrangement with outside hospital suppliers, including other providers, are subject to CMS 15, provider reimbursement manual principles of reimbursement. So we have an example here for you that we wanted to share in reference to contractual agreements. Okay, and keep in mind, when it's a contractual, there will only be one bill that is submitted for payment to Medicaid. So the example we have is prior to the transfer, Hospital A contacted Hospital B to discuss the transfer and the expectation of the patient returning to them. That agreement was reached that Hospital A would reimburse Hospital B. Now, however you all do your agreements, that is up to you with how that piece of it goes, okay? So the member was admitted to Hospital A and being transferred to Hospital B because Hospital A, as Lee stated earlier, can't provide the services that are needed. So the member was at Hospital A from 1/1 of 23 through 1/14 of 23. Hospital B provides the required services, so the member is admitted in their facility for 3 days and transferred back. So they're at Hospital B from 1/14 to 1/16. And then they're transferred back to Hospital A. And they're at Hospital A from 1/16 and completes their services all the way to discharge. So once that has been completed, Hospital B will submit their entire bill, everything that pertains to that inpatient stay during that call will be submitted to Hospital A for the services that were rendered. Hospital A will then add all of Hospital B charges to their claim. The total dates of service on this claim now should reflect from January 1st through the date of discharge. Okay. Hospital A will submit their claim to Georgia Medicaid. Georgia Medicaid will reimburse Hospital A, and it is up to Hospital A to reimburse Hospital B because, again, it's a contractual agreement. Okay, so we have another example here. And Lee, if you don't mind going over this example for us, please.
So contractual agreements are pretty common. And again, as Janey mentioned at the beginning of the presentation, it's really important that you give us as much information as you can at the point of PA submission about why the patient is being transferred, where are they being transferred, what service could not be provided at the initial hospital. So this is super common. So we have these preemies that are born all the time at Hospital A. 31 weeks gestation. This patient was transferred to the NICU on CPAP. His respiratory effort improved. He required continuous positive airway pressure, CPAP. He was tolerating his feeds well, working with OT and PT. The concern, however, in these preemies a lot of times is vision. So there is this particular thing that can happen with their eyes, the retinopathy of prematurity, or we call it ROP. At Hospital A, there was no retinal specialist available, and that's common. There usually wouldn't be someone like that. You would have to actually go to a children's hospital where they could specialize in something like this. So this particular baby on 114, they had him stabilized enough so that he could go to Hospital B and be seen by the retinal specialist, Dr. I, and then determine if he did need to have the immediate surgery or not. So they determined that he did. He did have the laser surgery. He received some eye drops post-op, and he was still requiring some help with his feedings and his oxygen support. So his stats were dropping while they were trying to feed him. So they continued with like the tube feedings. He was able to be transferred back to the initial facility where he was born. On 116, he required the nasal CPAP after his procedure. And then they gave him the directions about the eye drop. He had a little bit of swelling. And then they were going to attempt to wean him from CPAP to just be on room air oxygen. The parents were educated on his post-op care and the plan of care. He remained stable, and at that point, he was still in the facility. So we treat this as a contractual agreement, but again, we would have to know that these two facilities have a contract. So in the clinical we call it the back page of where you submit your PA, where you can type in those comments. If you would just let us know that that service cannot be provided or a patient needs a higher level of care, then the Hospital A would have the PA, and Hospital B would have to be reimbursed by Hospital A for the procedure that was done that Hospital A could not provide.
Thank you for that.
And then I just wanted to go over the following things that could affect your PA review and your billing rules. You have to make sure. Today is April. I have a little visitor with me. Make sure if you do have a PA and you have one of these, especially like these sick NICU babies that are going to be there for an extended period of time, you only need one PA with a recertification after the 90-day span. You don't have to keep on submitting duplicate PAs. We want to eliminate that provider administrative burden as much as possible, make it more efficient for the review. You'll get your review decision much quicker. Also, if there's ever a transplant that's included in any of these transfers, so whether it's an in-facility, in-network transfer or an out-of-network transfer, it's really important that you let us know that. There are some billing complications that can occur, and we have to do some behind-the-scenes work on the transplant piece so that provider doesn't get two whole DRGs and that we're making sure that the payments are appropriate. As Janey said, and I continue to stress, just make sure that you let us know if there is a contractual agreement. If it's not noted, we just treat it as such. Then you could submit a reconsideration, contact us, whatever, just to let us know or give us a call. And then let us know if the patient does have retro eligibility, because that's also going to affect your timeliness on your PA, and if we need to include all dates of service on one PA, et cetera. So it's just really important. The more information that we have on the front end, also contact us is a great way to contact us. We get those turned around really, really quickly. If you go on to GAMS and submit a contact us under prior authorization, sometimes it will give you the exact like PA type, but as long as you can get it under the prior authorization link, you can ask us any questions about, you can either note the PA in the contact us, or you can have just a general generic inquiry. We get those turned around usually in a day, sometimes 2 days, but it just avoids a phone call and you're going to get a much quicker answer. So all of those are attached to the subsequent PA. If there's no PA, we have another area where they're actually recorded. So the other way that you can contact us is through the 1-800 number. But again, the contact us is going to give you a much quicker response. You don't have to sit on that phone for so long.
Thank you so much for that, Lee.
Yeah, you're welcome.
So as you all know, normally when you have contractual agreements or the transfers, sometimes these are really large. These are really large claims that may possibly end up being reimbursed for outliers. So we wanted to let you all know how outliers come into play with contractual and transfer agreement submissions as well, and what you, the provider, needs to do to make sure that your claims process accordingly. You all know that I am a firm believer of process of elimination. Exactly what is it that I need to do to submit my claim so when it's submitted out, it's going to process correctly. I'll get my DRG from the DRG if it qualifies for outlier. What is it that I need to have in place with this contractual and or transfer to where it's not going to deny and I won't have to do anything else? So what you would do is exactly what you see here. You need to indicate in the cover letter or your comment section that this is a contractual or this is a transfer agreement submission. You need to have documentation from both facilities, okay, that will deal with this outlier. And that documentation would be your UR notes from both facilities with the UR plan. Each facility should have a discharge summary for each transfer. Each facility must complete the physician progress notes. So you should have that from both. We have had providers where they sent over half of it and not all of it, and you have to go back and do this again. You need to make sure that you've combined the itemized bill and the UBO for totals. They should all match the bill claim. Everything should match up when it comes to that reimbursement. That itemized bill should be attached from both facilities and should be combined into one document. So when we say that, we're saying hospital A, you have revenue codes for pharmacy as well as revenue codes for lab. And I'm just using these as an example. Instead of you having it separated on an itemized bill, you need to have all the pharmacy charges there, all the lab charges there. It should not be separate. They should all be combined. So if it's under 250, combine everything under 250. 300 needs to be combined under 300. 301, et cetera, et cetera. All of that needs to be combined into that one document so that is not missed. I also asked Ms. Davlin if she would share a little information with you all as well with the importance of the outlier review once you submit the documentation over. Davlin, can you talk a little bit about that?
Sure. Once the outlier is submitted, it's very important for the nurse reviewers to know that it is a contractual or a transfer agreement. That way you don't receive an unnecessary denial due to the nurse not being able to determine that the member hasn't been transferred back and forth because of missing documentation. The nurse will see it as you're just missing documentation for a review time frame, and they might deny the outlier review. One thing that the nurses do look at is your UR plans for each facility. So for example, if they were at Hospital A, we're going to look at the UR plan for Hospital A. We will look at the UR notes for the adherence to the UR plan. And then if they go to Hospital B, we're going to look at Hospital B's UR plan and the UR note adherence to the plan. So that is something that the nurses will look at with the reviews. As we said, it's very important to combine your itemized bills so everything is on one bill. And your itemized bill totals and your UB totals should match your claim totals. That's very important also. All right, Janey?
Okay, thank
Thank
you
you.
for that. Thank you. Okay, so now we're going to talk a little bit about policy information and updates that we have. The first thing on here that you see is the upcoming change for the end of the continuous member enrollment notice. And I'm sure every last one of you have seen this because you all go out there and read your banner messages as requested, right? So with this one, we were letting you know beginning April 1st, so this has already began of this year, all Georgia Medicaid and Peach Care for Kids members will undergo an eligibility review. This process will take approximately 14 months. A member's date for redetermination may be anytime between April of 2023 and March of 2024. Notices will be sent to all members, so please ensure your contact information is up to date. If the state finds that a member is still eligible for Medicaid, coverage will be renewed. If a member is no longer eligible for Medicaid, he or she will be connected with an alternative healthcare option. So we've provided 2 other links for you all to look at for those options. But I know you're probably saying, okay, Janey, so this is for the member. What is it that we need to do as providers to ensure that we're billing the right way and that it does show this member as being eligible? You, the provider, you truly need to verify that member's eligibility every time your services are being rendered. So the question was asked to me in one of my conference calls, well, what if they have a surgery and we've already got the pre-certification for that surgery? Do we still need to go back and verify that the member has the coverage? Yes, you do, because authorization does not guarantee your reimbursement, okay? But that will be the only way for you to know if the member is truly eligible for those dates of service, okay? So please make sure you do that. Please go out there and look at the information we've provided for the members. If you see that they no longer have the services, you have these links that you can direct them to and help them to see if they may qualify for any other type of healthcare options. Okay, and then the other updates I have for you pertain to the HCPCS 2023 code. So as we do every year, there are new HCPCS codes that come into effect January 1st of 2023. And there are old HCPCS codes that are terminated December 31st of 2023. All of that has been loaded into our system. The mass adjustment has already taken place as well. So you all should be on point with that. And if it comes to any of the HCPCS codes that you receive and your denial is stating that is not valid for the dates of service, go out there and utilize that procedure search panel. Put that procedure code in there, enter your category of service or your place of service, 21, 22, 23. And if your category of service shows, it will give you the dates that is covered. If that category of service is not there, then that means that that HCPCS code is not valid. Ladies and gentlemen, we have the Medicaid Spring Virtual Fair that's taking place April 20th of 2023. That information is provided for you all as well out there under the banner messages. And once again, I'm going to state that I know you all have seen it. I know you're getting ready to register for it, and you're looking forward to it as well. One of the things that I did look at with that, and I think that it was a great decision that DCH made, is where they have your CMOs with their own sessions. So you will be able to talk to your CMOs during their sessions and ask questions, and get what you need, because you have that hour time span, I believe, to do that. Also, one of the updates that I did not post in here because it came out after everything had been approved pertains to next month. We will be having the webinars for SNF, the skilled nursing facilities. So go out there and register to attend those webinars in May as well, if you are SNF providers. I think that's going to be really helpful for you. But remember to read the provider messages and take time to pull and review the information provided to you. We've done that to assist you when you're not able to attend the webinars, the workshops, or the Medicaid fairs. This colored screen that you see here, it just outlines the different territories for you with the color range of how they are sectioned out. This next screen provides you with the provider relations field representatives. Okay, so you are able to see your territory. If you're in Northeast Georgia, then that means that you are under Territory 3. And if it does not pertain to hospital, your rep would be Carolyn Thomas. Okay, if it does pertain to hospital and it's Territory 3, then your rep would be Sharita Bentley. So this is how this section works. We also provide statewide consultants, and they are awesome. You have Brenda Hewlett, you have Sheree Daniels, and you have Danny Williams. I'm sure if you all have ever attended a Medicaid fair where we were physical, you came across these people. Okay, so we'll talk a little bit about the contacting Gainwell technologies that we have available for you. We have the IVRS system, which is your voice response, the provider service contact system. We also provide the GAHFMA system, and you have us, your provider representatives. We're all here trying to get this job done to accommodate and help you at the end of your day. So with the IVRS overview, if you dial the number, you have the option 1 through 6 to select what your issue is about. Upon you selecting that, then that's when you will receive that person and you can, discuss whatever that issue may be. Okay. With the provider contact center as well, we assist with the claim status, eligibility, prior authorizations, remittance advices, demographic changes, et cetera, et cetera. However, we are available for you Monday through Friday, no weekends, no holidays, from 7 a.m. to 7 p.m. One of the other great things that we have is the tool for the Contact Us link in GAHFMA. So if you need to contact your provider directly, you're going to log into the MMIS system with your username and your user password. You'll log on. Upon you logging on, you're going to select the web portal option. With you selecting that, you can go to the Contact Us. Upon you doing that, then you can request the things that you see here. Contact your provider rep, or if you need to request a visit, you're able to do that as well. The things that I really like to hit on is when you're under this contact information, please do not just put in there, I need my rep to contact me. Tell us a little bit about your concern. I have multiple ICN numbers that are denying for duplicate, and I'm not understanding it. ICN number, you can provide 2 examples of that for us to review. Make sure when you leave us your contact information, if it's a phone number that you leave, make sure that it has a voicemail, and make sure that it leaves your name. Your name is on there, because if your name is not on there, then we're really not allowed to leave information on there because we don't know if that's you. So make sure you do that. Make sure you also provide us with a valid email address where we can contact you with that method as well. And we also have a new system that's called GABI that's also available to provide you with some quick information or quick responses as well. But ladies and gentlemen, I hope that this presentation was very beneficial for you. And we are now at questions and answers. So Bill, I'm turning it over to you.
Thanks so much, Janey. I appreciate it. Great job. Davlin, Lee, thank you so much for all of your input. That was a lot of good information. Folks, now would be a great time. Any questions that you have, please drop those down in the Q&A section on your screen, and we can ask those of the group. Janey, one that I had that someone had submitted to me ahead of time, or is there, and you may not know the specifics of this, but one of the folks on the call may, any information you need the providers to be familiar with as it relates to the Medicaid redetermination process, which started April the 1st and will run for the next 14 months, in which the hospitals have to essentially determine which of the folks are still eligible for Medicaid. That's expected to be, I think, about 2.7 million people in the state of Georgia. But is there any, I've found some resources online that are provided by the state and by DCH that seem to be very thorough and very helpful. Just wanted to see if there's any additional information that anybody would add from you or any of your colleagues today related to that.
Well, we actually have the presentation posted out there on the provider notices. Bill, you're going to have to put that on mute.
Oh, sorry.
Okay, great. Thank you for that. Guys, we have an echo thing that's going on, so we're trying to keep that out. But yes, we have posted the information from DCH. Miss Lynette Rhodes gave a fantastic presentation on that. So it's under the provider notices, and they can pull it under the end of enrollment provider continuous stay. So that's available to them. And if they have any questions after they review that, by all means, create the CTN for us to review it, and we'll get back with you if you have additional questions or concerns.
And Janey, can I add, that will also be a session at this upcoming Medicaid fair. The state, Lynette Rhodes and her team will also be doing a session at the Medicaid fair. You want to make sure that you attend that as well. But like Janey said, there is a presentation posted on the GAHFMA site under provider information, subcategory provider notices, of the content that was reviewed at the hospital association. So you can definitely see that there, but that is a session that will be happening at the Medicaid fair. So that is definitely something you want to look forward to attending.
Great, thank you for that, Sharana.
Yes, Sharona, thank you. Appreciate that. I'm not seeing any questions coming in, so I guess you guys again did an exceptional job today in covering everything. And we appreciate it so much. One last chance. Anybody want to drop anything into the chat or the Q&A for this group before we let them go for the day? All right. Well, again, I want to thank all of you for your participation today. Got some good things coming up with Georgia HFMA. We've got our Spring Institute coming up the 3rd through the 5th of May up at the Avalon in North Atlanta. We encourage you to look into attending that event. There's some other good networking events going on. The access to the Georgia HFMA website is a little bit different. Janey, if you'll go ahead and unshare your screen, I'm just going to show folks here real quick how to get on. Hang on just a second. All right, hang on for me just a minute. So let me get to the end here. Just going to show you how to access this.
You're on mute.
It's not going to let me do it. So just go to hfma.org and then click on find your chapter, go to that, click on Georgia, and then that'll take you into all of the information about Georgia HFMA and the different events that are coming up. They've moved to a new platform, so everything's on one platform. But I think that's going to do it for today. I hope that everybody has a great week. I hope that you can join us for our sessions the rest of the week. And as always, we thank you for your support of Georgia HFMA, and thanks to the folks from Medicaid today for all of their input and information. Thanks so much, y'all.
Thank you all very much.
Always a pleasure, Janey.
You
Thanks,
too.
everyone. Bye-bye.
Bye-bye.
Thanks for having us. Bye-bye.
Thank you.
Sure thing.
Bye-bye. Bye-bye.